I'm vascular medicine physician here at Prairie Heart. I've been here 80 years now, or something like that, long time. And let's dive into it. I've been specifically asked to talk about chronic venous insufficiency. Um, I know this is a topic that's originally foreign to a lot of cardiologists, a lot of cardiology practice, nurse practitioner, advanced practitioners. If you have any questions, feel free to ask me in the end, in between, if you need to stop me, because I prepared this some time ago, and I'm going to run through some slides because they're not practical to a point of view of prevalence and all, but it's very prevalent disease. So again, we're going to talk about chronic venous insufficiency and then venous testing and everything. All right. Right. This is my disclosures. I have no financial disclosure for this talk. If it suits you, you can refer vascular patients or particularly wound patients to me at Vascular Clinic or St. John's Hospital Wound Center. Actually, there's a wound center in Effingham also. And there's a wound center that will be opening at St. Anthony not St. Anthony, St. Francis Litchfield also next month onwards. Prevalence for venous insufficiency. Let's just say it's very prevalent. If you see venous insufficiency, varicose veins, maybe a little more so in women than men, though there's more literature coming out that's almost as common, though men doesn't seem to complain about it as much because it's cosmetically not that big an issue for men, but they still have significant disease. So just to numbers, prevalence of varicose veins, venous disease is more than 20%. 11% men, 22% women, older age 40 plus. Over 20 million males in the United States have advanced skin changes or venous ulcers. And as we are noticing more and more older age and more patients are living, thanks to partly you guys yourselves, we're keeping patients alive longer. We're going to see more and more medical problems. I wanted to make the concept of venous insufficiency in two subjects. One subject being primary venous insufficiency due to refluxing or leaking varicose veins. And second venous problem is that's probably going to be more and more common down the road is venous disease due to obstruction, which is due to prior DVT or proximal iliac or venous disease, iliac veins, IVC vein, probably iliofemoral veins that causes something that's called post-thrombotic syndrome. So there's two separate problems in venous disease itself, which is venous insufficiency, which leads to venous hypertension, and obstructive venous disease that leads to venous hypertension. The primary basic etiology, if you look into pathophysiology, is venous hypertension, high pressure in the veins that leads to venous insufficiency, whether that's due to refluxing veins or even heart failure that have more volume in the legs, or as compared to obstructive pathology. Next slide just introduces the concept of post-thrombotic syndrome, which is what is a complication of DVT, venous thrombosis in the legs. It develops in 20 to 60% patients of all DVT. With full treatment, with full appropriate treatment, that's the prevalence of post-thrombotic syndrome. 5 to 10% develop severe PTS. And what is severe PTS is when you have leg pain with heaviness, tiredness, that you just cannot walk. You have to elevate your legs and leg kind of drains out it helps you. Then venous insufficiency changes with skin ulcerations, advanced venous changes like lipodermatosclerosis, etc. Has a significant morbidity, mortality complications. As annual cost of PTS in the United States, it's supposed to be $7,000 per patient a year. I also wrote that this is the most frequent complication of DVT. I'm not sure that's right. The most common complication of DVT is venous valvular reflux. So deep veins, if you look at the blood clots, they form right behind the vein valves. That's where the veins start. So what happens is rather than keeping the venous valve competent, it modifies the valve so valve doesn't close properly and it leaks. So you see a lot of venous testing that I order. We see deep venous insufficiency. So if there's a lot of deep venous insufficiency, that patient most likely had DVT at some point, and that's causing deep venous insufficiency. Or there's a proximal venous obstruction in the iliac veins or IVC that's causing also. So it is a very frequent complication of DVT, though I would think that the most frequent complication is venous valvular insufficiency in the deep veins. What is the prevalence of venous disease? Again, I think I'm going to go run through these slides because it's all I'll say. It's very common. If you look at this here, truncal veins, 33% men, 26% women. Hyperweb, which is reticular veins and spider veins, 80%, 80%. Reticular veins, 80%, 85%. So basically, it's very common. Again, these are different trials that we've shown how many patients just had a screening program, how many patients had venous disease, 200 patients underwent screening program. And then look at this, just 30% of those, almost 30% of those, just in a regular screening program, had venous insufficiency. Yes, majority had low level venous insufficiency. And I'm going to go through these classification of C0, C1, C2. And you'll see in my notes, a lot of time I'll see chronic venous insufficiency CEEP5 or CEEP6 or CEEP4, I'll write. And I'll use Roman numeral, which is the right way of doing it. So, and then that's what I'm really referring to, and you'll learn what I'm referring to: C0, C1, C2, C3, C5, C6. Again, this is again another publication, how common and prevalence and distribution of CVD. As you see, chronic venous disease is more common with lower degree venous disease and less common with higher degree venous disease. In my practice, I have way more of these than these. These don't come to me, and these I don't see even much. I'll treat beauty treatment if they need to be, but just because I am in Prairie Heart, I go to St. John's Wound Center, I get a lot of patients here, a lot of patients in C4, C5, C6, and I'll go through it a little later. What is the problem in venous insufficiency? The problem in venous insufficiency, underlying problem is venous hypertension. So high blood pressure in the veins. And that's due to two reasons. One, as I talked about, is vein reflux, so leakage in the veins. Second problem, leakage in the veins is, let's say, primarily due to venous insufficiency from varicose veins, etc. Or it could be venous reflux from persistent and residual venous obstruction. So there's some leakage that happens in the veins from prior DVT, or if proximally in IVC or iliac, there's some obstructive pathology, let's say May-Thurner or something, and it's causing obstruction and the vein starts leaking as well. So this is a vein, and we're giving the corresponding pictures here. If you see, these are normal valves. When the muscle pumps, when the blood, calf muscle pumps, when we walk, this goes up and down, and calf muscle pumps, blood goes up, and the valves close. These are competent valves. Valves close, so blood that went up doesn't come down. All the veins have valves, including the deep veins, including iliac veins even have valves, but very few. And these valves increase more as you go distally. In a patient with venous insufficiency, what you get is incompetent valves. So the blood clot, either due to incompetent valves or the blood clot that happened right behind the vein valves, it makes the valve incompetent. So blood goes up and then comes down, which is not what it was supposed to in a normal competent valve. So blood goes up and comes down, and what you get, more blood in your veins, and you get venous pooling from extra, and then you get venous hypertension. So this is a concept of the calf pump. Veins of the legs do not have a heart. How does the venous blood gets back to the heart? It does not. Veins don't have a heart. This is the heart of the veins. See how we're pumping the calf? We walk up and down. This is what constricts the muscles, pushes the blood up from the veins. This one goes down, this one goes up. And if you have a competent vein, when you relax, the competent vein valve does not let the blood come down. Does not let this goes up and this does not come down. Competent vein valve stops this. So when you walk, this goes up. When you walk, this goes up. When you walk, this goes up, and all the way. When it gets to IVC and iliac veins, even our deep breathing takes the blood back due to negative intrathoracic pressure in the chest and heart. So it goes into right atrium. It's even the deep breathing process helps it. So the respiration, you can see changes in respiration even in lower extremities. If I have a common femoral vein flow, I'll be going like this in a vein. If I'll ask them to like do Valsalva, it'll just stop. You'll see venous blood stopping. So changes of respiration, changes intrathoracic, intra-abdominal pressure, changes the veins, venous flow down in the extremities as well. So this is how what happens in patients that you do when they have problems or not. When you do calf pump exercise in a normal patient, you see in a normal patient, you do calf pump exercises, quick, fast, up and down. The pressure goes in a walking patient from a pressure of 80, 90, goes to 20, 25, and it takes a good 30, 40 seconds for the pressure to fill up to that level. So when we look into patients who have varicose veins, I ask them, do you stand a lot? Do you walk a lot? And then you'll see a lot of these patients just stand a lot. Stand a lot is not good because when they stand a lot, they're here all the time. They're here because the venous hypertension in a normal supine pressure, the leg pressure is down like 5-10 millimeter even. But in a standing patient, it goes to almost 75-80. But in they're standing all the time like here. Can you guys see my arrow moving when I'm doing this?
Yes, we can.
Yes, we can.
So this is where the venous pressure is when you're standing. And you walk, it goes, comes down. In a normal competent system, it takes a good amount of time for pressure to build up. In a patient with incompetent venous system, where the venous system is not right, first, if you see the baseline pressure is high to start with, it starts in 90-95. And you do calf pump exercises, it does not come down to 25, it comes down to maybe 50, and it fills up pretty fast. Why? Because either there's significant leakage in the veins that causes venous hypertension flow coming down, or there's proximal obstruction which does not let the pressure come down even also, and it fills up very fast. So this is another example. You have a normal patient from 80-85 comes down to 20-25, takes 40 seconds to go up. And then in a patient with venous valvular reflux disease, it pushes down, comes down to half, and it quickly fills up. This patient number C has proximal venous obstruction. So when he does the calf pump exercises, it doesn't even come back. It doesn't even get down much because there's persistently obstruction proximally. So it stays there and there's no refill time because it never came down. So there's no refill time. Refill time is essentially zero because it never came down less than 90-95 to start with. So this patient number C, what does he benefit from? The only thing that he benefits from is lay flat, put the leg up, and then do calf pump exercises. That's when he benefits from, because he cannot benefit from doing calf pump exercises with just standing anymore, because the pressure never really comes down. He always feels with walking, the leg is just bursting heavy, just bursting because the venous pressure, the venous flow is never able to get out of the leg. Next slide is a very interesting slide. This exactly talks to what I was talking about. So patient is lying down. Your pressure is almost 5-10 millimeter mercury, which is what the right atrial pressure is. So when you're laying flat, your leg pressure is equal to what your right atrial pressure is. You're down to 5-10 millimeter mercury, and in a normal healthy limb, you sit up, it starts increasing, you start standing up, and you've stood up for a few minutes, it goes to almost 70, 80, 90, and then you start walking around, it goes down to 20, 25, and you stand and do not move anymore, it starts going up again. Just like I talked about in a patient who has reflux, when you lay flat through collaterals and all stuff, their pressure also comes down. And then they start getting up, it goes up faster as compared to healthy male. It goes up actually a little higher than a healthy human body. And when they start walking, it does not go back to a normal level of 20, 25 where we should be. It goes down to 50, 60, 70, depending upon venous reflux. If it's completely venous reflux due to varicose vein, it will come down here. If it's due to bad obstruction proximally, it will come down here or even higher. And when he stands, so basically what I was talking about, you can clearly see here, these patients have underlying high pressure in the veins, even when they're getting up, even when they're standing, even they're walking. No wonder their legs are always hard, painful, heavy, bursting all the time. What are the symptoms? What are the clinical signs of venous disease? Typical symptoms are pain, heaviness, tiredness, fatigue, sensation of heaviness and swelling, itching. You see these venous eczema on these patients, or see venous itches them, pruritus. Sometimes you get burning pain, and that venous claudication is what I'm talking about. Is in those severe patients when they have proximal obstruction, where they walk or their leg just feels like heavy and just gonna burst, and the only thing that relieves it, they have to raise it up and then do calf pump exercises. Calf pump exercise is doing nothing. It's just putting the heart of the veins in motion. With your ankle goes dorsiflex up and down, up and down. So that's just putting the heart of the veins. The calf pump is the heart of the veins in motion and get the blood back. So that's the symptoms. What are the clinical signs? And I'm going to show you slides also. But let's start first with signs. Swelling. Again, swelling is so multifactorial, and especially in a prairie heart patient. I mean, who doesn't have swelling? 70–80% patients have swelling because they're all cardiac patients. So edema, I take edema with a grain of salt and blame it on venous disease, because there's just, I mean, all of our patients right now are, they're not good specimen to start with, except I'm not talking about the 60 or 55-year-old cardiac patients, but the majority patients these days are heavy, sleep apnea, morbid obesity, diastolic dysfunction, AFib. The AFib is a very important thing also, because AFib leads to loss of atrial kick, which decreases effective ejection fraction by 10–15% maybe, and that 10–15% also tips the patient over. These are typical patients, sleep apnea, they sleep in a recliner, they can't even sleep in a bed. And sleeping in the bed is important because, as I showed you, laying flat, you see how the pressure comes down. You sleep in a bed, so you're sleeping in this position basically. Oh, I'm sorry, sleeping in a recliner. You're sleeping in this position. Depending on how bad you are, your pressure the whole night was maybe 60, 50, 40, I don't know exactly what, but roughly like this. Because he's sleeping in a recliner essentially. The guy who sleeps in a bed, that's why you see me talking to patients all the time, try to sleep in the bed. Because once they sleep in the bed, their pressures are down. And once they start sleeping in a recliner, that's their pressure. Somewhere here, I can't say where exactly, but somewhere here their pressure is. And even when they say that I try to put my leg up, it's never up. It's never up to the point where it's at the level of the heart. And sometimes they sleep more in a V position. They in a V position where the flow comes and gets stuck basically in your proximal pelvic area. And sometimes they sleep in something what I call a W position, when their knees are the highest. If they think, oh, I'm putting my legs up, where knee is the highest, and then the calf goes down again, which really doesn't help. The calf pressure is still high. The blood needs to come back from the foot to calf to thigh and down here. So coming back here, what are the clinical signs? Edema, I talked about. It's a common sign, but edema is very multifactorial. You get telangiectasias, which are very small spider veins, venous dilatation, ectasia, varicose veins, redness, erythema, eczema. I'll show you some of these pictures. Pain during calf compression. This is again, your leg feels even bursting when you walk because the pressure, because when you're walking, you are not able to relieve that pressure upstairs. So this is the classic venous claudication, pain during calf compression. Lipodermatous sclerosis, I'll show you some of those pictures also. Atrophic blanch, which is white healed skin. You can see there's a venous wound and it heals and becomes atrophic blanch. And I'll show you those pictures as well. So symptoms of venous disease, remember I said C0 to C6, and I'll talk about this. C0 is the earliest symptoms where you have symptoms of heaviness, tiredness, fatigue, pruritus, um, Charlie horses at night, itching, but does not have any varicose veins to look at. Then higher level, you have these symptoms, and then you have the smaller varicose veins, smaller varicosities, which are telangiectasias and reticular vein. And what is telangiectasias? These are the spider veins, which are 1 millimeter or less. And what are reticular veins are 3 millimeter and less. If I were to treat these veins, I have to offer them cosmetic treatment. Insurance doesn't cover this treatment. Insurance starts covering treatment from C2 onwards, which is varicose veins. And you can see varicose veins here. What is the definition of varicose veins? Definition of varicose veins is 4 millimeter and more is a varicose vein. So this is varicose vein. C3 becomes varicose veins plus swelling. And you can see that swelling there. Again, I also call a lot of patients C3. Frankly, I'm unsure all that C3 is due to venous insufficiency because that patient is obese, patient has diastolic dysfunction, AFib, morbid obesity, sleep apnea, yada, hundreds of reasons to have sleep apnea, basically lower extremity edema. Calf pump failure, there you can see there's a walker in the room, they don't walk well because the calf pump doesn't work well. And calf pump is what gets the blood out of the leg. And then you get C4, which is you start getting venous stasis changes. C5 is a healed ulceration, and C6 is an active ulceration. So once you have an ulcer, you're always going to be C5 or C6. So once this heals, it becomes C5. There's a new wound, becomes C6. You're never going to go down here, even if it does not have any large varicose veins. I think a lot of C5 disease that I call in the wound center has nothing to do with venous disease. A lot of C5, actually I call C5 because that's what I'm supposed to, is secondary to fluid overload / venous disease / congestive heart failure / biventricular heart failure. Has nothing to do with varicose veins because there's no varicose veins on those patients. This is just extra volume in the legs from heart failure / whatever, diastolic dysfunction, this and that. So I call it C5, C6. Ideally, I should not, but then there's no other way to call this volume overload ulcer. And there's no word as volume overload ulcer, but what does volume overload lead to? Volume overload leads to extra fluid in the veins and the legs, which seeps in extra interstitial tissue, and that essentially starts leaking and becomes a wound. So this is typical. I was talking about the telangiectasias. These are the spider veins and some reticular veins in between there. But this is called Khurana Venous with ankle flare. I used to struggle classifying these patients, but a year ago, venous disease got divided into, there was always C4A and C4B, but they made C4C, which is higher level than C4A and C4B and C4C. So this ankle flare became C4C. So a lot of these patients, you'll see me call them C2 before, and next visit a year ago or some ago, I started calling them C4C. And that's the change because classification for venous disease started calling them C4C. This ankle flare / Khurana Venous, these smaller veins at the ankle, we see a lot. I knew this meant higher disease. There was no way to classify this, so now we call it C4C. So in C4A, you have mild venous stasis changes. C4B, you get advanced venous stasis changes, lipotensinosis. Sometimes you feel patient says, I have this feeling of hardness in my distal calf, localized, and you can see the skin's kind of hard there. That's localized lipodermatosclerosis, and that's advanced venous disease. That's C4B, not just C4A with just venous stasis changes. So these are varicose veins. These are smaller reticular spider veins, but ankle flare. These are varicose veins. Again, example, you see these are spiders, reticular veins in between, but majority spiders here. A heel ulceration, an active ulceration. This is classic gator area. Classic distal medial calf, and this area, and sometimes in the foot upper area. This is classic gator area. These are typical venous wounds. If you have a leg wound and you close your eyes, leg wound from ankle or let's say medial malleolus or ankle, leg wound from here to here or here to here. If you have a leg wound, you close your eyes and say that's a venous wound, you are probably 90-95% correct. That's a venous wound. You're probably 90-95% correct. That's a venous wound. All right. So this is edema, and I think this is venous edema due to venous disease because you see this discoloration right here. This is a healed ulceration from the past. You can see this white stuff becomes atrophic blanch, and this is also healed ulceration. You can see whitish stuff, atrophic blanch, and this is discoloration. A lot of these patients, every chronic edema in long time starts getting some degree of lymphedema. So you'll see me a lot writing in my notes, chronic venous insufficiency with phlebo-lymphedema. What I'm trying to say is that this patient never really had lymphedema to start with. It's because of his multiple medical or venous disease that he has developed lymphedema also on top of his phlebo means veins from the chronic venous disease that has become phlebo-lymphedema. So this is classic atrophic blanch here. This is the healed skin. And also you see if how this leg is like inverted champagne bottle sign where your ankle is skinny. If you put a champagne bottle upside down, that's what it looks like. You have skinny, that neck of the champagne bottle, and it kind of widens up. This is not as classic as a picture that I've seen many patients. I don't know if I have that or not, but this is, I just wanted to introduce a concept of lipodermatosclerosis. There is one just localized lipodermatosclerosis where you'll have hardness, feeling of hardness in the patient, darkness and hard. That's localized lipodermatosclerosis. But the classic lipodermatosclerosis, you have a leg like this, and you have a leg like this coming, and then just champagne bottles, inverted champagne bottles. Active venous ulceration. You can see venous changes. You can see those smaller varicose veins slash ankle flare slash corona phlebectatica that I was talking about. Again, a venous ulcer. Again, a venous ulcer. You can see irregular sloping. You can see drainage in them. Wounds here are generally all venous. At this area of the ankle, they're all venous wounds. Rarely there's different kind of wounds, but a wound looks like this is venous wound. And what is the treatment of venous wound? It's compression, 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 compression. This is the treatment of venous wounds. You have to do compression. And long term, there's only two C's that are important: compression and compliance. I cannot stress you enough how many times I see patients in the wound center, I heal their wound, and within a month or two, they're back because they're not well combined with compression and leg elevation. And intervention if there's deep venous obstruction, that's my job. If I missed it, it's my fault. Ablation, if superficial venous, if there's superficial vein leakage, I have to fix that. That's my problem. That's my issue. Intervention if there's deep venous obstruction. But if there's deep venous obstruction and there's nothing to be done, then there's nothing to be done. I tell patients that majority of the deep venous, I don't want to do anything about if there's nothing proximal. FemPop, there's a lot of people doing this trial, that trial. It has never shown to work anything. I mean, all these trials have been negative up to now. All these DVT trials have all been negative, and we keep trying more and more because technology is getting better and people start making, borderline indications for many other reasons than patient's best interest at heart. And I'll leave it at that. But that's what you need to do. What is compression? This is a typical compression stocking. If I was giving a presentation live, I'll show you my stocking. I wear stocking pretty much every day at work. This, I'm assuming, let's say this is a 20-30 compression stocking. What does a 20-30 compression stocking mean? You have 30 millimeter mercury pressure at the ankle, which is the highest point of where the venous problem happened. People ask me why this is the highest point where venous problem happened. The venous column, the man is a venous column or woman is a venous column. Where is the highest pressure in that venous column? The lowest part of that venous column. And this is the lowest part of that venous column. When he's standing, or she's standing, this is the lowest part of the venous column. The highest pressure is right here. So you need 20, 30 millimeter mercury, 30 here, and goes to 20 here. I have a lot of times seen patients wearing the new athletic stockings that start here and finish here. And I tell them that you're actually making your problems worse because your highest pressure is actually here. The highest pressure is here, and you're putting a stocking from here to here. This is actually leading to somewhat constriction and reduced outflow from here to there. So you're making yourself worse. So anytime you want to give compression, even if it's a 15-20 or a 10-15, 8-15, because the patient doesn't have the strength to pull it up, you need to give a stocking that covers the full leg. You can give a toeless, or you can give it toeless or with toe, but it has to cover this gaiter area. This is the gaiter area. It has to cover the gaiter area. Right? Okay. Zippered stockings comes. These are zippered stockings, makes it easy for some people. I'm not a big fan, but if patient doesn't wear stockings because they cannot have do not have the strength to pull it up, this is one option. There's something called a sock donor, SOCK sock donor, DONNER, donor. You can come to my clinic or my office sometime, and Denise can show you. Sock donor is also very helpful for helping the patient don the stockings. And I understand it's a chore. I mean, it's a real chore. Putting the stockings up every morning, taking off at night, then putting up every morning. For some of these patients who cannot bend, they're older folks, they just cannot bend, they have a big belly. I show them how to bend their leg and put it on the thigh and then do it. Some of these people cannot even do that. Some don't have the strength to do it in their fingers, in their hands anymore. I have one patient in the wound center who's had extensive bilateral venous ulcers in both legs, one leg for 40 years, one leg for 25 years. I saw her first day. I was like, these are long-standing wounds. They look like classic venous ulcers. But 25 years, I'm not going to take chances. I did venous income testing. There was some deep venous reflux. I sent her to IVUS, venography, all negative. And finally, everything came negative. I told her, the reason they haven't healed is because you've been non-compliant. I mean, there's no other reason. Either you had a bad doctor who didn't know what to do, or they're just non-compliant. And I'm proving right and right because the wounds are healing well with just regular venous treatment, but just made me nervous when wounds were there for 40 years and 25 years in one leg and 25 in another. Like I had to rule out serious stuff. If I knew this has been only there for 2 months, I didn't have to rule out into all this stuff. But 40 years wound, I don't take chances. Like, what if there's, you start thinking of funky stuff. But essentially, now that she's almost getting close to healing, I shouldn't say close to healing, but she's 50% better in both legs. We have started talking about compression long term, and I realized what the problem is. The problem is that she has severe RA. She has severe RA. Her hands are all crooked and turned over, and she cannot put even a 10-15 mmHg, millimeter mercury compression stocking. So I told her, maybe you can do, there's a different kind of wraps that come, that Velcro garments. She said, I can't even do that. So that maybe 40 years ago, wounds were smaller, they healed, and she just keeps recurring because she doesn't have the strength to put compression stocking. So I have her, I have her family coming next week, so I can talk to her. It's like, I'll heal these wounds. It'll take me another month or two to heal these. But long term, they're not going to stay healed if she doesn't do compression garment in the long term. This is a wedge that you can buy from Walmart, Target, or somewhere. This is ideal for leg elevation. When you tell patients to put pillows, it doesn't work very well. Pillows sag and they go where and where in the middle of the night, you never know. So this is what helps. This really helps patients a lot. And a lot of patients have told me it does help. It just, their compliance goes down over time. These are also compression stockings. I don't like these, and these are the sheer kind. And then it's good to have because if you're going out, you're wearing a nice dress or a skirt or something, these will work well. But these are very flimsy. They get they get runners and tears in the garment, and once you get runners and tears in the garment, they're not good anymore. Um, you can see them. Some of these are just skinny garments. This is what I was talking about. Uh, Velcro kind of garment. There are different garments called circades, ready wrap, ferro wrap. I have some pictures here. These are different garments, and but the important thing to see is you have to have the foot covered. A lot of these garments, the Velcro garments, come, but it has to be a sock liner with that. That sock liner is very low pressure, but you have to have a sock liner. If you just put this and don't put a sock liner, you're possibly exacerbating higher venous pressures at the gator area. See, this one also has compression right here too. And then there's an underlying sock liner that goes through. I don't like these as much as I like compression because it depends how tight the patient is going to put it. Patient can put it mildly, moderately, tightly. That really depends on the patient. When compression stocking goes on, it goes on. I mean, either you don't have it or you have it. But this one, you may even have it, but you may not be tightening it enough, where you're not velcroing it on as far as you can to get the ideal pressure. This is Pro 4. This is what I use in the wound center a lot. A multi-layer wrap. These four wraps goes onto them. Venous wounds drain a lot, and that's what helps absorbing the drainage. And sometimes I have patients come 2-3 times a week, depending on how much drain it is. A lot of cardiology patients, Nalamatu, Megan Seacrest, all these, seems to have the worst patient with all this heart failure and all. A lot of patients with few of them with Jennifer Black, but seems Nalamatu's patients are the one probably just because of his practice. A lot of heart failure patients that I have them come a couple of times a week, even to change because it just seeps through. And you can see all the four layers are going in. The last layer is the Coban to hold everything on. But this first wrap, second wrap, third wrap, and then the fourth wrap here. This is Pro 4. This is what I use mostly at the wound center to help them heal the wound. Another example of Pro 4. And what is Pro 4? You get compression stocking of approximately 40 millimeter mercury down here with multi-layer wraps. So essentially what I'm doing is the same that I talked about. I tell patients in simple terms that think of skin as a garden. Your garden is full of water. Grass is not going to grow. We need to squeeze the water out of the garden. So you put the leg up or you compress. Either you elevate this or you compress. What you're doing is taking the water out, and essentially it is water out in the garden there. Too much drainage going on in the wound's not going to heal. So the concept in wound center is very easy. If the wound's very wet, you need to dry that wound. Or if ischemic wound, which is very dry, you need to little moist the wound. So that's the overall concept. So these are wet wounds and you need to dry them. So 40 millimeter mercury, 20 here, and you put them on and you heal them. You look at the wound. This is the patient up here. There's the leg down here. You can see I've already healed this much of that wound already. I remember this patient. This is from a few years ago. This is from Carlinville area. This hole is a wound initially when I saw him. This is already healed significantly. You can see this already little left, and this completely. And this is what I was talking about, atrophic blanch, where it's the discoloration, light color discoloration of the new skin. And this is my own patient. You can see my foot here, my shoes that I used to wear. And this is, I think, from New England Journal. I took pictures. But again, these are classic wounds, venous wounds. You can see this is, I don't know if. So here now this is that typical lipodermatous sclerosis also, maybe where you have inverted champagne bottle sign. You can see that also. Once you tighten it, you have this, and then it goes up. You have a Pro 4 going on, and the wound heals. So this is from venous insufficiency. This is a patient I saw years ago. This is from my fellowship training. There's a young, maybe 35-year-old, 37-year-old guy who had varicosities right above his pubic area, right above his pubic area. What was happened was he had a DVT 10, 15 years ago. His iliac veins are completely occluded, completely occluded. So what is this? This is collaterals coming from internal iliac, going to that side, dumping here, and this is training all the blood back. So what is happening from the venous? The blood comes out, comes here, and goes to the heart. And then that's how this guy is opening. So he has started developing some skin changes in the legs. For a 40-year-old guy, he wasn't advanced C4B, he was only C4A. He did not have a venous wound at that time, so no C5 or C6. So we actually sent him for intervention to have his iliac veins opened up. The iliac veins basically had occluded due to DVT. And what happens in a lot of these iliac veins that occlude due to DVT is because this iliac artery compresses on the iliac vein down here. The iliac artery compresses on the iliac vein. And this is what's called classic May-Thurner syndrome. And that is why actually if you see left leg DVTs are almost 60-65% of all DVTs, because most human beings, or almost 30 to 40% human beings, have some degree of compression from normal artery crossing onto the right side and causing episodic compression with every heartbeat. It causes compression, and worse with more compression than others. And then that's how with long-term compression you get scarring in the veins, webs, and eventually at some point you get a DVT. The classic DVT, you can see thrombus in the vein, acute, dilated. This is the artery here. How this is like almost double, triple the size of the artery. This is classic large new clot that does that. This is again typical. You have that occluded iliac vein, and you can see collaterals going on to this side, or collaterals going to the lumbar, or collateral just like my patient with prominent suprapubic veins in the abdomen. Sometimes you cannot even see the veins, and majority it's all inside internal iliac vein to internal iliac vein, and that going up there. But that patient was just a classic to rule out. What do you do? How do you make sure that you don't have problems when you treat compression? Venous disease patient needs compression. You just need to make sure that they don't have moderate to severe PAD, so that you know that you're safe for compression. I tend to get ABI as an arterial duplex. This is what a typical ABI. This is what a typical ABI is. You get both arm pressures, and the higher pressure you take, and you throw with the lower arm pressure. You take DP, dorsalis pedis, and posterior tibial, dorsalis pedis and posterior tibial, and the higher pressure stays, and the higher pressure stays, and you get higher ankle pressure, higher arm pressure, you get ABIs. Anything more than 0.4 or less is severe PAD, 0.41 is mild to moderate PAD, 0.4 to 0.7 is moderate, 0.7 to 0.9 is mild, then this is borderline, and this is normal. And this is what I use in my clinic. One of these Doppler waveforms I have this Doppler right now, but I've used this one Doppler too. Basically, it's very common to not hear the arteries, so you use Doppler waveforms to see. Okay, what superficial veins are in the body? You have great saphenous vein, small saphenous vein, anterior axillary saphenous vein, posterior axillary saphenous vein, intersaphenous veins. And there's a lot of perforators. And what's a perforator? Perforator is a connection between deep veins, which are the deep veins that has thrombosis, DVTs and all, and the superficial veins. And I'm going to give you a diagram that you can look and see. So this is a deep vein going in. What you have is saphenous vein that goes on the inner thigh. And you guys all know saphenous vein because it's the most common vein that gets used for cardiac surgeries. And then you have small saphenous vein in the back of the calf. And what happens when you have leakage in these veins, you start getting varicose veins. So I can look at a patient by the location of the varicose veins. I know most likely what kind of reflux the patient has. If there's leakage here in this along this course, I see large varicose veins. This is most likely a GSV reflux. If there's something in the back or towards the other lateral malleolus, lateral gator area, then it's probably SSV reflux. Though there's a branch of GSV that wraps around and gives flow on the other side too. And if it's an anterior thigh, that generally means anterior accessory. So anterior accessory comes, so of GSV comes on the anterior thigh, posterior accessory goes even posterior thigh. So this vein, this leg, as you can see, most likely has GSV reflux. You can see all these varicosities are in the medial thigh territory. And you can see advanced venous changes on these. I'm not sure if this is a wound or not, but these are really advanced venous changes. Then how do you diagnose venous incompetency? This is here we are doing a reflux study. I wanted to show you, this is the pneumatic pump that we use. This pneumatic pump with a cuff is down at the ankle of that patient. What we do is we use a cuff, it inflates quick, 1 second inflation, blood goes up, and in a competent vein, blood should not come back. Blood goes up from here to here and should not come back. Blood goes up from here to here, should not come back. What we have, our probe is on a GSV right now. We're looking, blood goes up, it goes up, and does it come down? You can hear it actually. It goes up and then it's coming back. I can actually hear venous leakage on my simple handheld Doppler that I use for arterial testing, where I do because I'm looking for the arteries, and that's the blood coming back that you can hear. So this is what this patient is having, a venous income testing. It's a long 1.5-hour test. We make sure there's no DVT. Then we scan, we Doppler the whole deep system, then the superficial system, make sure we're not. Make sure we don't have any superficial superficial venous incompetence. And this is what the reflux I was talking about. You do a quick, that's the pneumatic cuff that sends the blood up, and this is what you hear coming back. A normal you'd be and this one comes back and the valve closes and there is no reflux back. This reflux is telling you the valve is not closing, so you have incompetent valve there. This comes back here. I'll try to go quick on these. Again, this is deep system. You have GSV here. In the back of the calf, you have small saphenous vein, the small saphenous vein, and this is where you get anterior accessory, and this is where you get posterior accessory. Here, just like I was saying, anterior accessory goes and posterior accessory goes on the back side here. And this is the GSV all the way down. This is the GSV, and right, this comes anterior accessory. So I see veins in the anterior thigh that go lateral. I know anterior accessory is the vein that's causing it. Sometimes you get lateral plexus, which is very subdermal plexus, which is very smallish veins. Oh, here is what I was talking about. So spider reticular, this is from the lateral plexus actually. What do you do? Ablation on these veins, it's just showing an ablation with small saphenous vein. When we do ablations, we have to be careful. You don't want to go too much down because the sural nerve gets closer to the fiber tip and you sometimes get a nerve injury. We talked about treatment of venous ulcers is compression. You do arterial interventions. Normally, you don't do arterial interventions on venous ulcer. It's a venous problem. You need to compress the vein. When do we do arterial interventions? If my ABI is low, you want to do arterial intervention so I can safely compress the vein. So if I get an ABI of 0.4 or 0.5 or 0.6 even, and I look at the toe pressures also in those patients, what I want to do is I'm not opening the arteries for the wound. Wound is not going to get healed with opening the arteries. A lot of people think, it's a lot of poorly trained wound doctors or vascular doctors. All they see is a wound and then they want to open the leg. On a venous wound, actually, you're going to make it worse because more flow down there. It's going to have, as you've seen after intervention, patient gets edema in the leg. So your venous wound is actually going to get worse. But what I'm trying to achieve is Once you get my more flow, I can do multi-layer wraps on those patients. So the and that's the whole point of doing arterial interventions on a venous ulcer.
So I have a question about that, Dr. Khurana.
Yeah.
So even if the patient is asymptomatic, they don't have any claudication at all, in order to provide safe compression, you would recommend intervention?
If I have a venous ulcer, if I have a
If
venous
you have a
ulcer,
venous ulcer. Oh, okay.
there's an AVI 0.5. Yes, I want to do it then.
So if they just have like edema and you want to provide compression, that's not an indication for intervention?
No, no.
Okay.
No, I mean, you know, a lot of intervention gets done, maybe not in our practice, but because most doctors in our practice, use good, proper, sound medical care. Your indications for treatment in PAD or critical ischemia means a wound is not healing, which is arterial wound, and I did not show any pictures of arterial wound, or you're trying to open bad arterial circulation on a venous wound, or there's a neuropathic wound and the circulation is not good. And if you do want to do with claudication, it should be lifestyle limiting claudication. And really, nobody should have any procedures done without having trials of a walking program, without having trials of cilostazol. And then if he still cannot walk 50 feet, 100 feet, yes, you can make an indication. But vascular care has in some ways, um, um, you know, there's a lot many procedures done by doctors who sometimes don't know what they're doing, basically, and then it's not right to do. And then there's a genuine critique when I hear it sometimes, so I'll tell you a real life example. I had a patient with bilateral venous ulcers. Again, he was a big guy. This is 6-7 years ago. I said to Goldstein, Goldstein opened one leg, and I did compression, wound healed within 2-3 months. The other wound also had long SF occlusion. He sent it to Gopal Das. Gopal Das refused. The ABI was 0.43 or something, or something 0.4. And I'm kind of stuck, interventionist, as long as if occlusion didn't want to do it. Cardiac surgeon declined, and now I have a wound to treat. So I gently, I never put him on Pro 4. But I put him on a 20-30 compression stocking, and I don't think I went 30-40, but I put him on 20-30 compression stocking. I told him, if your legs or toes get numb or painful or gets a little dark color, just take your stockings off. Because once you put Pro 4, you can't really take them off, and that's the whole point, that you risk ischemic limb if you put too much pressure, and this collateral could be a superficial collateral, and you've compressed it, and you could have toes that are ischemic looking now. So it took me a good 6 months, but I healed that wound. I would gentle compression, not deep. I did gentle debridements, not deep debridements. I put him on just 20-30 compression stocking, and I eventually healed him with the ABI 0.4, or something. It was poor ABI, I remember. And I remember that patient because I was nervous with him. This is years ago when I started doing wound care here. One leg, I had no problem healing because interventions opened the SFA. I had good flow. I put him on Pro 4, multi-layer wraps. Fine. The other leg, I had to struggle for 6 months before it finally healed because I was going slow. I did not want to compress the leg too much. So this is part of the quiz of these. One other question somebody asked me is, when do you do venous testing? So when do you do venous testing will come down to when you see these things in the leg. Anytime you have leg pain, I guess you can do it, but this is when you want to do venous testing. You have heaviness, tiredness, fatigue, you see some veins, which is very common in our practice. And venous stasis changes, these are venous stasis changes. If you just look at your legs of your patient, you'll be surprised how many patients have venous stasis changes. And I'm not saying everybody needs to have venous reflux testing, no. But venous stasis changes already mean we're dealing with C4, C5, C6 disease. We're already dealing with high end venous disease. And not all this is venous problems. Not all of this at all means venous problem. All that means is there's high pressure in the veins. And what is the most common of right heart failure? Left heart failure. So I now realize what is the most common of venous stasis now? Most common cause of venous stasis now is just high pressure from the heart that's coming down, whether that's from severe MR, severe AS, diastolic dysfunction, sleeping in a recliner, AFib or hypertensive heart disease, long-standing hypertension. Cardiac issues or sleep apnea or COPD are the most common reasons for elevated high pressure, which basically gives you undiagnosed pulmonary hypertension, and you see the effects in the legs. Um, So I told you almost, we'll just go through the question. What is the treatment of venous ulcers? I think you know, these are the question part. Offloading, if you have a wound on plantar aspect of the foot, which is a neuropathic wound, pressure wound, you need to have total contact cast, offloading. What is the pathophysiology of venous disease? We talked about, can you have deep venous reflux? Can you have superficial venous reflux? Deep venous reflux happens due to prior history of DVTs or proximal venous obstruction. Superficial venous reflux is that varicose veins and all causing superficial venous reflux. Deep venous obstruction can also cause, so these questions are for you to answer. What is the most common complication of DVT? Post-thrombotic syndrome, heart attack, PE, CVA. I would have made it difficult if I put it venous valvular reflux, then it would have been a difficult answer. But these are easy. When is it not safe to prescribe compression? As I told you, it would not be safe to prescribe compression when it's really low. You can make an argument of 0.7 also, but I've done a lot of 0.7s and I've healed them. Another thing to realize, 0.7 in an 85-year-old male, female may not be accurate. It really might be 0.4, 0.5 because these patients have non-compressible calcified vessels. So 0.7 may not be accurate. So it's important to look at the toe pressures also in those patients. And generally, I also actually do duplex. So there's big time occlusions I see, then that 0.7 may not be accurate. With that big time occlusions or problems, this patient may really be 0.4, 0.5. And just because of calcified vessels, the pressure is on the higher side. What are other factors important? And I think there are a lot. And you see me talking in my assessment plans, I'll say it's multifactorial. And actually, these days, before 10 years ago was not as much, but I think overall population just getting older and more comorbidities, and all these comorbidities are present in those patients, especially in a cardiac practice. So if you see, you see this wound, I'm asking what kind of wound is this? Is it an arterial wound? Is it a venous wound? A neuropathic wound? None of the above. And I'm pretty sure by now you know what kind of wound is that. Okay, now feel free to ask me questions.
So I have another question. Obviously, we should try compression before we basically anything else is what it sounds like you're saying. But then, so when do we refer them to you? Like if they're having edema and it's not getting better with compression socks, or they have varicose veins that are very uncomfortable and they're still uncomfortable with compression stockings?
So varicose veins, C2 disease, you should put compression stockings. You should put compression stockings irrespective whether you refer to me or not. Okay, 20-30 compression stocking. The indication for treatment for compression for those varicose veins is symptoms that don't go despite compression stockings. I've had patients, but those are minority, not common. But I've had patients that I put compression stockings and they come back after 3 months. And I looked at venous testing and I go in thinking that I'm going to talk about ablation, ablating the GSV or SSV. I go in and the guy says, "Oh, my pain's all gone. Thank you for giving compression. As long as I wear compression, I don't have any problem." So you don't have to refer every patient. It's up to you. But the patient that I'm going to intervene are patients that are having symptoms despite conservative care. And unfortunately, the problem with compression stocking is not me, not the compression stocking, not you. It's the patient who does not wear compression stockings on a regular basis. It's the compliance that is the problem. So there's two C's that are important in venous care: compression and compliance. And when there's a wound, I put multi-layer wraps and patients cannot take it off. So once I compress, the patient heals, but they're always back because the compliance is lacking.
That makes sense. I have another question. When should we evaluate for May-Thurner syndrome?
So that's a good point, Meredith. Let's go. So if you look venous income testing, okay. So let's say somebody has a DVT, all right. If I look DVTs in popliteal vein, femoral vein, and if it does not say it's common femoral vein, I will not look further. I have to have the most proximal vein involved to go into May-Thurner in acute DVT. So acute DVT, if the clot is in the thigh or popliteal and not in the groin, then there's extremely low chances of having May-Thurner. Now, if you see clot all the way from common femoral, popliteal vein, then you should look for proximal obstruction. Now, in a chronic patient, how I evaluate May-Thurner is if there's extensive deep venous insufficiency, not just little insufficiency here or there. If there's extensive deep venous insufficiency, I evaluate for central obstructive pathology. Now, sometimes I've seen that extensive superficial venous reflux ends up giving deep venous reflux also. So it could be that I may ablate the patient and still the symptoms not going away. I may look for it, but I generally, if I am suspicious, I'll look for central obstructive pathology first, then I'll go to superficial. Though different people do different. I mean, that's how I do it. If I'm more concerned about central, I'll rule out central obstructive pathology. Then I'll go treat their superficial venous pathology if I need to. But I always look for central first if that came to my mind. Sometimes when you treat superficial venous reflux, your deep venous reflux can also improve it because it might be all coming from superficial venous reflux.
Okay, awesome. Does anybody else have any other questions for Dr. Khurana? All right, well, thank you guys so much for joining us. Dr. Khurana, thank you so much. It's as always a great talk and I get so much information from each one. So you guys be careful and have a great day.
All right, thank you very much.
Thank you.
Thank you. Take care.
Bye.